Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 13-year-old male who is a migrant worker who came to ER with complaints of high-grade fever with chills and rigor associated with joint pain for the past 5 days.
Yes.
Sir, on initial 10-second assessment, the patient was conscious and oriented and was obeying commands. Coming to the primary survey, the airway was patent and there was no pooling of circulation. And the breathing air entry was bilaterally equal with a respiratory rate of 22 per minute and saturation of 96% maintained in room air. And in circulation, his BP was 138/80 mmHg with a pulse rate of 91 per minute and all peripheral pulses were palpable. And disability wise, GCS was full score and pupil was equally bilaterally reacting. And the temperature, he was having a temperature of 100 degree and he was IV cannulation was done and paracetamol IV was given, 1 gram was given. And later on coming to the went ahead with the secondary survey, and the history is like he's a 39-year-old male with no known comorbidities and he was hailing from Madhya Pradesh with last visit 1 month back. And he was not having any history of any comorbidities and he was complaining of high-grade fever with chills and rigor and joint pain since the past 5 days. He was also complaining of dysuria and dark colored urine since the past 2 days. And there was no history of any abdominal pain, cough, breathing difficulty, vomiting, loose stools. There was no any allergic history. So we went ahead with the blood routine examination, and which was showing a total count of 4.7 with 4,700 with platelet count of 43,000 and HB of 11. And as right now we get the provisional diagnosis of fever with thrombocytopenia, and so we as Kerala is prevalent for most dengue fever, we initially sent for dengue and peripheral smear. With the dengue antigen came out to be negative, and he was as a migrant worker, so as he was hailing from Madhya Pradesh, there is a high chance he might have malaria. So we went ahead with the malaria antigen test, and malaria antigen test came out to be positive for Plasmodium vivax, and also we got result from the peripheral smear which was showing malarial parasite. And we said also the other routine investigation as malaria can cause hepatitis and all. So the OTPT was within normal limits, 39 and 62. And other than that, his CRP was on the higher level, 171 was the CRP. And INR was 1.19, APTT was 29. Other than that, his lab was normal, and urine routine, as he was complaining of dysuria, urine routine was sent and it was showing 0 to 2 pustles only. Okay. No UTI as such was noted.
Okay. So what is your final diagnosis?
Diagnosis is Plasmodium vivax malaria.
Okay. First tell me, how do you manage this case in emergency room, then we'll discuss.
So as such, for emergency management, a patient is having a high grade fever. Right now for the fever, we can start him on IV paracetamol and for reduction of the temperature. And later on, for the patient, as he is not complaining of any features of severe malaria was not there.
What are the features of severe
malaria? Is a condition where the patient is having Plasmodium falciparum infection with any of the following symptoms like impaired consciousness, shock, seizures or acidosis, hypoglycemia, pulmonedema, ARDS, then renal impairment, anemia, severe anemia, HB less than 5. Then these are the main features of severe anemia.
Tell me how falciparum malaria produce all these things. Impaired consciousness, myocardial infarction, liver dysfunction, kidney failure, hypoglycemia, hemolysis. What is the mechanism behind all these things?
There are multiple mechanisms. The thing is, falciparum malaria has a high parasitic index count. So a lot of parasite will be released. This will cause hypoglycemia. As such, the parasite will take up lot of glucose.
Utilize
glucose. Then the other thing is, these parasites cause adhesion, cytoadhesion occurs. Adherence occurs, which will cause the.
What is this cytoadherence? What do you mean by cytoadherence?
Cells will clump together.
So there will be some protuberance on the RBC if the cell is infected with malaria. So these cells will stick together, RBCs. So then what will happen?
This will cause a stroke, MI.
They produce microcirculation block. That is the main problem. Microcirculation occlusion will occur. So patient can have stroke, myocardial infarction, eye problem like sudden visual loss. Everything can happen. Liver injury can happen. But hemolysis is entirely different. That is because of the rupture of the RBCs. Hypoglycemia is due to RBC. This malarial parasite utilizes the
Large amount of glucose.
What is the basic difference between falciparum and Vivax in terms of clinical finding?
Clinical findings, the falciparum causes severe high-grade fever with chills, whereas
Vivax also produces high-grade fever chills.
And the Vivax and all has a recurrence, like a periodic recurrence, whereas
So they can
falciparum doesn't
have
have
recurrence can be there.
Whereas falciparum has relapses,
Reinfection, relaxes. Okay.
Then the fever will be like tertian or cotton fever in cases of Vivax and malaria, whereas in falciparum there is no such difference between this.
The main problem is the number of parasitic index is very high in falciparum, and number of RBCs infected are high, and all the age groups of RBCs are involved in falciparum, but that is not the case in Vivax. These are the major differences. Okay. What are the CNS manifestation of malaria?
Cerebral malaria. The patient can have like altered sensorium, seizures, or patient can have syncope.
Okay. Can seizure is a part of other features of malaria? Malaria alone can produce seizure. That is because of the cytoadherence. Can any other condition in malaria produce seizures? Hypoglycemia is one of the conditions. That's why coma unrelated to hypoglycemia. That's why we tell it as coma unrelated to hypoglycemic episode in malaria is defined as cerebral malaria. Okay, because coma can be due to seizure itself. Okay, sometimes seizure can lead to coma. Okay, so seizure is the main problem there. Okay, any other complication other than what you explained?
Then patient can have jaundice.
That is liver disease.
Hepatitis.
Any ABG disturbances?
Acidosis, lactic acidosis.
Lactic acidosis is one of the most important problem of falciparum malaria. What is the reason for lactic acidosis?
Hepatitis
No, hepatitis will not produce lactic.
And hemolysis.
Hemolysis will not produce lactic acidosis. What is the reason for lactic acidosis?
Cytoadherence.
Same thing. The problem what you explained, obstruction of microcirculation in the brain, kidney, liver, that can happen in the intestine, internal circulation also. So that produces decreased circulation to internal tissues, that produces lactic acidosis. So that is one of the condition you get multi-organ dysfunction like is malaria. That is all due to the cytoadherence and block in the microcirculation. Okay. How do you manage this case in your emergency room?
So
whether it is falciparum or Vivax, treatment is almost similar in our country. Okay.
So earlier we used to do with chloroquine treatment. Right now, as the
chloroquine or quinine
can be given. So multi-resistant malaria parasite has been in the higher side.
Can you tell me the dose of chloroquine? Tell the dose of quinine. Tell the dose of what is it?
Artesunate.
Artesunate.
So chloroquine initially we had to give a 600 dose. Then we'll then taper down to 300 dose. 300
chloroquine is available as chloroquine sulfate. Okay. Each tablet contains 75 milligram chloroquine. 150 milligram of chloroquine, 250 milligram of chloroquine sulfate. So 600 milligram 4 tablets you have to give. Okay. Then
we'll half the dose, 300 mg is given.
Okay, 2 tablets should be given. Then another 2 tablets should be given. Okay. Other than like chloroquine resistance is very, very common in India. Quinine is the next option. How do you give quinine in admitted patients? Previously, quinine was the drug of choice. Now also some areas quinine they use, but most of the areas in India is resistant to quinine. How do you give quinine? What are the side effects?
Quinine has hemolysis chance is more in G6PD deficient patients.
G6PD deficiency is not in quinine; it is in primaquine.
Okay.
What is the what is the dose of quinine?
0.15.
Quinine is 600 adult. I am talking about 600 milligram quinine 8th hourly is the dose for adult. Okay, that should be diluted in
normal saline.
it should be diluted in dextrose.
Dextrose.
Because quinine is one drug which can produce severe hypoglycemia due to what is the reason for that?
Increased insulin secretion.
Insulin secretion can occur. So that you should keep in mind. And one more thing, it can produce arrhythmia. What arrhythmia it can produce? QTC prolongation and torsades de pointis. Okay, so that you have to take care. Because of all these reasons and rising resistance, we are avoiding quinine. Now we are using only artesunate. So what is the dose of artesunate?
Artesunate we give initially 120 mg is given at 0, 12, 48 hours.
Okay.
And later on daily doses is given according to severity of the disease.
Okay. Is there any adverse effect because of artesunate?
Artesunate usually won't cause that much of adverse effects, and
normally
sometimes
it is not
nausea, agitation.
So it is a very safe drug. Normally it will not produce any major adverse. Can you give it in pregnancy?
Yes.
So it is a drug of choice in now pregnancy. In all malaria, that is a drug of choice. Okay. So to avoid resistance to artesunate, it is not very well known. What else you can use?
Artesunate combination can be with doxycycline.
Doxycycline. So artesunate can be mixed with other combination like doxycycline, azithromycin. Like that, various drugs are given, but they are not individual drugs which can tackle malaria. It should be given only with the artesunate. That itself, it is not very proven that it can prevent resistance, but most of the doctors use it like that. Okay, so once you give artesunate, what is the next step?
Yeah, so artesunate is given to 3 to 5 days, and we'll start patient on Primaquine.
Okay.
So Primaquine initially 45 mg is given the first day.
Falciparum, it is 45 milligram stat. Then Vivax, this is Vivax.
Vivax.
How do you tackle that dormant form in liver?
Hypnozoites should be destroyed with Primaquine given for 14 days, 15 mg.
15 mg for 14 days. What is the most important side effect? It is not very common. Most important side effect of
G6PD deficiency.
G6PD deficiency.
Hemolysis occurs.
In patients who is already having G6PD deficiency, ideal situation you have to check the G6PD levels and give Primaquine. But in our country it is not practical. You just give Primaquine. What will happen suppose G6PD deficiency is there?
Hemolysis occurs, we have to stop the treatment.
How do you know that hemolysis is happening? How do you know that in patient intravascular hemolysis is happening?
LDH level.
Every day you will check LDH. Red urine is the signal that patient is developing intravascular hemolysis. What do you do if suppose the patient develops intravascular hemolysis?
To stop Primaquine.
You just stop it and give some folic acid. That is more than enough. Okay. Now what else you want to tell about malaria?
So Primaquine as such we can give non-G6PD and G6PD deficiency patient. If at all in non-G6PD deficiency we can give OD doses like 0.5 mg per kg, and if G6PD deficient patient we can give 0.75 mg dose weekly for 8 weeks. That can be.
Suppose this patient after discharge, after complete cure from this hospital, he may go back to his area for 1 or 2 months visit and he will come back. How do you prevent reinfection?
We can give doxycycline chemoprophylaxis.
Doxycycline is not the ideal choice. Mefloquine is currently the choice. Previously we used to give chloroquine. Now mefloquine is the current choice, and you can add doxycycline along with the mefloquine. Okay, doxycycline advantage it prevents malaria. It also can be give protection against which bacteria? Doxycycline prevention is given in which other bacterial infection? Flood areas routinely we give leptospirosis. So that protection also will be given. Okay. What are the different types of malaria seen in our country?
We have Plasmodium vivax, Plasmodium falciparum, and Plasmodium malaria. Plasmodium bronchitis and the lowers.
So other malarias are not very common in our country. It is our country commonest is vivax and malaria. That malaria is most important pathogen. It can produce cerebral malaria, seizures, multi-organ dysfunction syndrome, ARDS, all these things. So we have to be very careful. What is the role of steroids in malaria? Is there any role for steroids?
No.
There is no role. Which bacterial infection is common with malaria?
Salmonella.
Salmonella?
Gram-negative.
Gram-negative infection. What is that called as?
Algid.
Algid malaria. Okay. So some patients can have large spleen. So when you give this chloroquine and all, they develop one sort of syndrome. What is called as it? Maybe
Tropical splenomegaly.
tropical splenomegaly seen in malaria. Chronic malaria, it is a feature. If you give prophylaxis, they can develop black urine, all these things.
Black water fever.
So that complication can occur in chronic malaria, but we are not so much concerned because we are not seeing that much cases like other parts of India. In Kerala, it is very, very less. Okay, but where the malaria is very common, you can get tropical splenomegaly syndrome, black water fever, all these things. Okay, last case malaria we had, first patient had associated gram-negative infection. Salmonella was positive. So salmonella is very, very common. What happens to HIV in malaria? HIV also very common, not very common because of malaria. In HIV patients, malarial symptoms are very prominent. Okay, the reasons are not known, but malaria can produce severe clinical manifestation in HIV patients. Okay, that's all. Anything else you want to add?
And other than that, we can do the basic tests in malaria like thick smear, thin smear.
Okay, basic tests are thick smear and thin smear. Thick smear is used for
malarial parasite
to identify the parasite. Thin smear is used for to identify the species. What are the other tests you use to diagnose malaria? Now it is antigen test we are doing. Any other test is
quantitative Buffy coat.
Quantitative Buffy coat. What is that quantitative Buffy coat?
So we give the acridine orange color and it will find out the parasite.
So you can see the parasite in a different green color. Okay. So that is a most important test in malaria. But nowadays antigen is available. Point of care antigen is available so that we can pick up it early, much earlier. Okay. So is there any problem in suppose some patients here we are getting all these tests. Some peripheral centers you may not get all these tests very positive. So there is something called as cocktail therapy. What is that cocktail therapy? Coma cocktail therapy. It is not, we are not using because we are working in a medical college. We have all investigations available. But if you are working in a peripheral center, there is something called as coma cocktail. What is coma cocktail? So you should read about coma cocktail. Coma cocktail is somebody is admitted to your center where you are not able to diagnose. There are some important things which can produce coma. One is hypoglycemia, so you treat for that. One is malaria, you treat that. Third one is patient might have taken some sedatives like diazepam. So that also you have to treat. So 3 drugs will be given in the coma cocktail. Okay, that is a routine practice all over India, especially in peripheral centers, but not in medical colleges. Many doctors still practice that. Okay, coma cocktail you should read. Sometimes it will be useful, not in a center like this when you are working in a peripheral center. Okay?
Okay, sir.
Thank you.